So that really transitions to the mental health piece, because that's really, from a quality of life perspective, that is one of the bigger priorities for these patients. And this is a drawing that one of the Scad survivors drew and has shared. And I just think it's kind of a nice way of how some patients have expressed what's happened to them. So I'll start with the 2014 Mayo cross-sectional study, and this was done by one of our residents here who just essentially took the surveys of 158 patients at that time, because our registry has grown over time. It was mostly women. Mean age at time of heart attack was 45 years, and essentially we just looked at their GAD-7 and PHQ-9 scores, and it was a variety of follow-up time, but roughly at 37, 4 years follow-up was when these patients filled it out, and about a third of them were on medications for either depression and or anxiety. And the mean scores are actually mild or borderline, so not dramatic. But the interesting thing on this, those are the means, in case you're interested. But the interesting thing was actually the postpartum patients did have slightly higher scores than the other patients, perhaps because they're a little younger and it affected them differently. Stanford did a cross-sectional study. They invited 21 participants, but 14 female Scad patients participated. The mean age at time of heart attack was 51 years old. There was a bit of a range of age. They answered their questions, and they were all about 3 years post-Scad when they answered these questionnaires. Of the 14 women, 11 of them have some kind of history of mental health treatment, so the majority did, with diagnoses such as depression, anxiety, adjustment disorder, and PTSD. And also of those 11, most of them reported that their diagnoses and treatment were actually essentially related to having experienced with Scad. For this particular study, they had quite a few study assessments that they had the patients filled out. I have them all listed here. Essentially, they assessed for angina. They did the short form health survey, as well as a health locus of control. And then some of these other ones focusing in part on stress and insomnia, as well as, some of the common ones we know with depression. And their study results essentially is 93% of these 14 patients had stress based on these questionnaires. And this is kind of a dumbed down version. I apologize, this is the cardiology version. 71% had anxiety, 57% had enough findings to suggest insomnia, 36% endorsed depression, 43% fit criteria for PTSD. And that's in comparison to 12% of patients who've had a heart attack. So that's dramatically higher. And then the health-related quality of life and social support measures were very comparable to all-female cardiac studies. And then patterns of perceived control were actually more similar, in the author's opinion, to cancer patients rather than cardiac patients. And what they meant by that, and I found this really interesting, was that patients ranked chance more likely than self-control to impact medical outcomes. And I think that just reflects the fact that this is we have a new realization of this in the world of cardiology, and there's a lot we don't know about this diagnosis. There's a lot we can't really do to prevent it from happening again, and that's where we're focusing a lot of our research. But when you're counseling patients and you're being honest, you're telling them that. And so I can imagine where they're feeling like maybe chance plays more of a role than anything they might do, because essentially a lot of them feel like they're living a perfectly heart-healthy lifestyle, and yet they still had a heart attack, and kind of like, whoa, that doesn't make sense. Kind of unfair. The University of Colorado Boulder did a social media survey, and what they did for this is they actually used some social media platforms to advertise this survey. Anybody could sign up to fill it out. It was self-reported Scad, so they didn't have quality control. It was just essentially someone who was told or thought they were told they had Scad filling it out. 409 participants. And it's a little tricky because they were asked to recall 1 year and 2 years prior to their Scad. Most, again, were women with a median age of 45 years at the time of their Scad. And the numbers of Scad ranged 1 to 4 Scads. They didn't really give a distribution, but I can tell you, at least from the registry, most patients have 1 Scad, then a subgroup of them have 2, then it's very smaller subgroup have 3 or 4. And it's really, when you start getting to 5, I mean, even in our registry, we look at those pretty carefully, and it's maybe 1 or 2, really less than 1% probably, at least in our current knowledge. Now, time from Scad to survey completion ranged anywhere between 2 weeks to 27 years. So if they have that patient who's 27 years out and is trying to recall 1 year and 2 weeks prior to their Scad, I question the integrity of that data unless they have an awesome memory, but I know that's kind of a limitation here. Although the authors realize that, and they just comment that most were within 3 years of their actual heart attack. And some of the assessments they included the social readjustment rating scale. And then patients were actually asked about stressful events specifically relating to Scad. And they added some additional ones that are relevant to Scad, such as conflict with close family members or extreme or unusual physical exertion. They had patients kind of do a Likert scale looking at their experience of each event and whether or not it was stressful. And they were asked about what kind of information they were given and who was giving it to them. And then I thought it was kind of a cool question, but they said, if you could describe your experience of Scad using one word, what word would you use? And so what they found was that patients tended to have moderate to high levels of perceptions of stress. Patients tended to say they received inadequate information. And in general, they tended to have really good experiences in cardiac rehab, and they were very much interested in professionally led online patient education or support groups. And this is just some of the tables from that study. And the things that I would probably highlight here is, of the stressful life events that patients endorsed, the majority described change in employment status or responsibilities, intimate partner conflict, or a change in health of a family member. It's kind of those are the 3 big ranking things of the different categories. And then here, the one thing I mentioned is when they talk about referral resources that were offered, the one that was most commonly offered was cardiac rehab, which actually tended to be the most helpful if you look at the perceived program helpfulness, as well as exercise programs. So those are kind of the 2 ranking ones. But then as you can see, other things patients mentioned were counseling, heart-specific support groups, and stress management. In regards to what patients were interested in for interventions post-Scad, a lot of them commented on the online aspects, like either patient education or support group. There were a few who were also interested in kind of more in-person education. And then when we look at other information in terms of how did patients learn about Scad after their diagnosis, a lot of them said that it was verbal information from their medical provider, and actually a fourth had no information given to them. They were just given the diagnosis and sent out. And a lot of them, vast majority, over 80%, felt like the information that they received at the time of their diagnosis was insufficient. And the majority actually went to an internet search to figure out what happened to them instead of hearing from the medical professionals. And then the one-word descriptor, which I actually think is really interesting, the most common word that was kind of put, and this is a free text, so I imagine they got everything under the sun, but a third used the word scary. 13, kind of almost 14% said surprising, 12% said life-changing, 10% said traumatic, and then 7.6% said uncertain. And they didn't go really into any of the others because I'm sure they received a smattering, but these are kind of some of the common themes that they picked out of that. Now there's a Dutch database, and again, a lot of these studies I'm showing you were essentially published in the last 1 to 2 years. So they're all relatively quite new, and actually a lot of them didn't exist last time I talked to Dr. Morrison, for instance. This is 172 patients who were included into this database. They approached 232, but the 172 is who they ended up including. With a mean age of 52 years, they don't clarify if this was time of heart attack versus time of survey. And they don't mention time to survey, but they have another paper where they do, and it was a median of 3 years. So I'm assuming that it was 172 patients in that paper as well. So I'm assuming it's probably 3 years here. And then these were the assessments that they included, including the GAD-7, PHQ-9, perceived stress scale. They also assessed fatigue, kind of body vigilance, the mental health continuum, and then they also checked for type D personality, which I thought was interesting that they'd focus on that. And looking at kind of some of their results, I think the ones I'd highlight is over half or about half of patients had moderate or high perceived stress. A lot of them had fatigue, so 56% had a fatigue, substantial or extreme. I will comment that anxiety, depression weren't as overwhelming. I mean, mostly around the 10%-ish range. And maybe 20% had kind of a type D personality. A quarter of them reported burnout. And then the one thing I want to highlight in this table, which essentially goes over comorbidities, but there is a lot of patients who had migraines, but then there's a lot of chronic conditions that have to do with pain, fibromyalgia, whether it be chest pain, which was 68% of the patients, which I have seen in clinical practice definitely over 50%. And as you can imagine, when patients come to clinic, I mean, they're struggling with a lot of these other symptoms. And when I talk to them, some of these patients, these symptoms didn't really flare or come to being until after their heart attack. So some of these patients were very, what's the word, felt very healthy, no symptoms, living their daily life. Then bam, they have a big heart attack, and then now they're struggling with regular chest discomfort or odd stomach pains or pain to their neck that reminds them of their heart attack. And it's not everybody. As you can see, it isn't everybody, but these are the patients that tend to come more often to clinic because they're trying to work through these symptoms. Now, this same Dutch group did do another study that was just published. It was a case control study, and I imagine they got this off of feedback because I've reviewed some of their studies too, and they've made a lot of improvements after they got input. But they compared these 172 Scad participants to 76 patients who had heart attacks for plaque, atherosclerosis. And the Scad patients were younger than those patients at the time of heart attack, and I think they had a hard time finding enough athero participants to kind of match to for that reason. But when they compare the two, the Scad patients tend to have more often an emotional precipitant 24 hours before their heart attack, so 56% versus 39%, even when they adjust for other covariates. And they did have, however, similar levels of perceived stress and fatigue at an average of 3.2 years post-hospitalization. So from this same group, I showed you that they had a lot of stress and fatigue, but when you compare them to other patients who've had heart attacks for other reasons, it seemed to be very similar in amount. And these are just the numbers for that. And then, when we look at this, a lot of them had the emotional distress, but usually it was an upset about something, is how they characterized it, that I think drove that difference. And then these are just kind of the different psychological factors, which again, when they compared the Scad to the traditional ACS, so people with plaque or atherosclerosis, cholesterol-related heart attacks, there wasn't a huge difference in some of these things. Now, the Canadian group with Dr. Sa up in Vancouver did an abstract presentation. They haven't published it yet. This is 2016, and I only include it because I think it's really interesting. Because so many of these studies are patients who already had their heart attack, now are several years out, and we're questioning them, and some might be a little, only a couple weeks out, and then some are maybe 10 years out, and then you get everything in between. But these were patients who were essentially queried as they worked in cardiac rehab, which usually is within the first 3 months after a heart attack. And they compared the patients who had Scad to the patients who had heart attacks from other causes. And in general, the Scad patients were younger, no surprise. They tended to have a lower body mass index, so perhaps less obesity and less risk factors. But they did have higher scores on the STOP-D psychological distress, the PHQ-9, and then the worry, anxiety, and tension questionnaires, suggesting that despite less, things like cholesterol problems or smoking or those sorts of things, they have less of that, but they have more of the psychological challenges, at least early on. Now, here at Mayo, we did a nice cross-sectional study using our Scad registry that Dr. Sawchuk had also participated in. And this is Alexis Johnson. She's a medical student here who at the time wasn't differentiated. She's now in her first year of residency for emergency department medicine. But she essentially worked through deciding what questionnaires to bring out. I mean, this is over the course of her whole medical school time. And I essentially executed this, and this has been recently published. But the assessments that we included here, and these were questionnaires that we sent to all registry participants, regardless of when they had their Scad heart attack or whether or not they had more than one, was a post-traumatic stress disorder diagnostic scale, the PHQ-9 and GAD-7, an anxiety sensitivity index, the Connor-Davidson resilience scale, a 36-item short-form health survey, and then we have a Scad-specific questionnaire that we like to include too. And in terms of those findings, 782 patients were contacted when the surveys were sent out, and we received 512 surveys. And I suspect this would have been more, but our original survey link didn't work outside the Mayo firewall, so we had to resend it. So I think we lost some interest with that, unfortunately, but still relatively good response rate. Most were women. The median age of time of Scad and survey completion was 47 and 52 years respectively. And then 82% endorsed some kind of trauma with mild or more post-traumatic stress disorder symptoms in 28%. And then symptoms of anxiety and depression were observed in 41 and 32% of patients respectively. And when we think of the trauma, the primary source of trauma when patients were questioned were serious or life-threatening illness, which we presume is most likely SCAD. And then there's a smattering of some other traumas that played a role too. When we looked, these are just the PDS-5, the PHQ-9, and the GAD-7, kind of looking at how the scores distributed. You know, I think a lot of us could say, even just looking at these graphics, the majority had kind of low or near normal scores. And then you can see as you get higher up, there's less patients, but these are the significant patients that we'd want to target in regards to their mental health. I mean, I think it's important for all the patients on these scores in the spectrum, but I think those who are kind of moderate or greater really could use some focused attention. But I have even had patients with mild symptoms who, when you talk to them in clinic, have struggles every so often, especially if they get their fleeting pain come on. It brings back bad memories. So some of the other findings from this study was this time from the SCAD event to the survey completion was associated with a lower GAD-7 score, which would essentially imply that the further someone gets out from their SCAD, the less anxious they are about it. And even in clinic, talking to some of these patients, some of them early on feel like a ticking time bomb. And the longer they survive after the SCAD, the less they feel like another SCAD is just going to immediately happen, and they feel less like that ticking time bomb. So I could see why this association is present. Those of younger age at first SCAD and those who had low resiliency scores had higher scores on measures of trauma, anxiety, and depression. And I think that's not surprising. Again, just telling us, what patients are we thinking of as being high risk for being affected from a mental health perspective. And then those with higher anxiety sensitivity had more severe anxiety and post-traumatic stress disorder symptoms. And then emotional and social quality of life was higher in those with a high resiliency score. So, some of the conclusions are based on the assessments we used, but at least, some of these findings suggest that if patients have good resiliency habits or skill sets, that they're able to implement them after having something like a SCAD, and potentially that helps them in regards to their overall mental health, anxiety, and depression. So essentially, the conclusions from this study were survivors of SCAD do have significant or at least notable rates of PTSD, depression, anxiety, which seem to be associated with lower quality of life, particularly among those with lower resiliency. And then again, just taking a step beyond from that, and even just thinking about the other studies I showed you, that screening and treatment for the psychological distress is advised, which probably would have to at least initially be done by a primary care physician or the cardiologist. But then that next step of behavioral interventions, therapy, what have you, things targeted about resiliency even, would essentially be getting our colleagues such as you, your group, involved in terms of those next steps for treatment to try to help patients.